Hello everyone, my name is Dr. İrim Çobanoğlu. I'm working in the International Patient Program in Koç University Hospital, and I'm very pleased to welcome you all to the 5th event of the Koç Healthcare webinar series. Today's topic is Multidisciplinary Approach and Advanced Techniques for Spinal Tumors and Vertebral Metastases. Our speakers for today's discussion are Medical Oncologist Dr. Sinem Akbaş, Neurosurgeon Professor Özkan Ateş, Radiation Oncologist Dr. Nilüfer Kılıç Durankuş, and Dr. Duygu Sezen. They will be lecturing us on general approaches to spinal metastasis from a medical oncological perspective, pathophysiology and medical treatment of spinal bone metastasis, minimally invasive surgery for spinal tumors, targeted ablative radiotherapy for spinal tumors, and stereotactic body radiation therapy for vertebral metastasis. After the presentation, we will be having a question and answer session. I'm handing over the microphone to Dr. Sinem.
Hello, thank you for a nice introduction. I will talk about spinal tumors and vertebral metastases from medical oncology view. Spinal cord tumors can be classified as primary or metastatic tumors, and primary tumors of spinal cord is actually very rare. It only accounts for the 2 or 4% of all primary CNS tumors. According to the anatomic location of the spinal cord, it can be classified as intramedullary, intradural, extramedullary, or extradurally. Intramedullary tumors are generally ependymoma and astrostoma. Also, intradural metastases are common, not common, but its frequency is increasing because of the MRI usage is increasing. And intradural extramedullary tumors are generally meningiomas and also nerve sheath tumors. Extradural tumors are generally metastases from other primary cancers. The presentational symptoms are most commonly pain. It causes nocturnal awakening, and the site of the pain also give information about the location. Neurological dysfunctions are also in clinic seen. It's sensory dysesthesia and muscular weakness, especially in the iliopsoas muscle. Progressive difficulty in ambulation can be seen, and severe distal sensory loss and sphincter dysfunction also may occur. Spine is actually a common metastatic site for many tumor types, especially breast, lung, prostate, lymphoma, and myeloma. About 10% of cancer patients overall present with the vertebral metastasis. On physical examination, a complete neurological examination should be done to define neurologic deficits and deteriorations. Patient's ambulatory status has important prognostic significance. As imaging, MRI of spine is a diagnostic study of choice. Almost all intrinsic spinal cord tumors and metastases enhance with gadolinium. As intramedullary tumors, they are majorly gliomas, but gliomas are 90% in intracranial location. Spinal cord gliomas are rare, and most of them are 60 or 80% are ependymomas. It's a disease of young people. The peak age is between 30 to 40 years, and optimal management is cross-satar resection. Postoperative radiotherapy after partial resection or biopsy is an option. There is no proven role of chemotherapy, and for neurofibromatosis type 2 associated spinal ependymomas, the anti-VEGF monoclonal antibody bevacizumab may be useful. There is a distinct type of ependymoma, myxopapillary ependymoma. It commonly arises lumbosacral spinal cord and filum terminale. It presents with low back pain with radicular or without radicular symptoms. Complete brain and spinal MRI is needed because the risk of seeding. Laminectomy with attempted complete surgical resection is primary management. Local recurrence factor is subtotal resection. and being under the age of 36 years old. As intramedullary metastases, they are rare, but increasing diagnosis with the increased use of MRI. 1/2 of the patients have lung cancer, also breast cancer, renal cell carcinoma, lymphoma, and melanoma are the primary cancers. Usually, these patients have widespread metastatic disease, and 25% have them actually leptomeningeal metastasis too. The therapeutic approach is fractionated radiotherapy. Also, Brown-Séquard syndrome is a common symptom. In Brown-Séquard syndrome, only 1/2 of the spinal cord is damaged, and it causes ipsilateral motor and sensory loss, and contralateral temperature and pain loss. Spinal meningiomas. Meningiomas arise anywhere in the neuronal axis from the arachnoidal cells, but most commonly they occur in the thoracic spine. They are slow-growing, invasive lesions, and may erode the bone. Complete resection is desired. If subtotally resected, they generally requiring further surgery. Radiotherapy or radiosurgery if further surgery not feasible. Chordiomas are rare bone tumors. They are remnants of the primitive notochord. They are locally invasive, frequently recur, relatively radio-resistant, and the location is 35% is skull base and 50% sacral region. Chordiomas treatment is wide local excision. Post-operative radiotherapy when complete excision cannot be achieved is done. And also definitive radiotherapy is an option for unresectable spine and sacral chordomas. For relapsing disease after maximal surgery or RT, molecular targeted therapies like imatinib, sirolimus, sunitinib, erlotinib is an option. Metastasis, any primary cancer can involve the epidural area, but most commonly we said prostate, breast, and lung cancer. It's particularly important because of the risk of epidural spinal cord compression. As you all know, spinal cord is protected by a ring of bones. If the tumor invades the epidural space, it can cause the compression of the spinal. It's a relatively common complication of cancer, and it causes pain, mechanical instability of spine, and potentially irreversible loss of neurologic function. Early recognition and diagnosis is essential to maximize neurological functions. There are many mechanisms of metastasis to vertebra. 85% is from vertebral body or pedicle. It's arterial seeding. And 9% is the tumor gains access through the intervertebral foramina. It's especially seen in lymphoma cases. And we talked about intramedullary metastases. They are seen in 4%. And for 1%, direct split to epidural space via Boston's plexus is seen, especially in the pelvic tumors, especially in the prostate cancer. With Valsalva maneuver, the abdominal venous drainage shifts to the Watson's plexus and it promotes vertebral metastasis. The location is 60–70% is thoracic spine, 20–30% is lumbosacral spine, and less than 10% is cervical sacral spine. As tumor grows, epidural venous plexus becomes obstructed and vasogenic edema develops. Glucocorticoids may help to resolve edema. If it remains untreated, spinal infarction occurs eventually. The clinical features are pain. Generally, it's at the level of the lesion, but referred pain is also possible. Often, it's worse at night, probably because of the diurnal variation of endogenous corticosteroids. And over time, the pain can be radicular. Pain on the movement suggests mechanical instability, which is an indication for surgery. And the spine instability neoplastic score helps us to give a surgical decision. motor findings represent advanced stage of epidural spinal cord compression. Patients may be hyperreflex below the lesion, and pre-treatment neurologic status and duration of ambulatory loss are the most important prognostic factors for regaining ambulation. A sensory level is present prior to weakness. Spinal sensory level is 1 to 5 levels below the actual level, and acyanic numbness and paresthesias can be seen. Lethargic phenomenon, it's a feeling of electricity down the spinal cord with the flexion of the neck, but it's not specific for the cervical epidural spinal compression. Other clinical features are bladder and bowel dysfunction, ataxia, caudecina syndrome. For diagnostic evaluation, magnetic resonance imaging of entire spine without and with contrast, and computed tomography of myelography where MRI is contraindicated. There are no role of plain radiograph. Imaging should be done as soon as possible and within the 24 hours. As treatment, immobilization only if suspicion of spine instability. We give high dose of steroids, like 10 milligram dexamethasone IV, and after that, 16 milligram daily in divided doses orally. Analgesia is needed. Steroid may have pain, but many patients also need opioid treatment. Since many patients are immobile, we also give venous thromboembolic prophylaxis. Surgery and radiotherapy is the main treatment. Chemotherapy is only option for a very chemosensitive tumors like lymphoma. And hormonal manipulation in prostate cancer and breast cancer is another option. If you look to the prognosis, overall survival is approximately 6 months in historical series. Median survival for patients ambulatory priority radiotherapy is 8 to 10 months compared with the 2 to 4 months for non-ambulatory ones. And for those who remain non-ambulatory after radiotherapy, median survival is only 1 month. Prognosis is better for hematologic malignancies, breast and prostate cancer, and is significantly worse for lung cancer. Neurologic function, pre-treatment neurologic function is the strongest predictor of post-treatment function. 80% of ambulatory patients remain ambulatory. Approximately 1/3 of patients with paraparesis regain the ability to walk with the treatment, and only 2 to 6% of paraplegic patients regain the ability to walk. As conclusion, spinal cord tumors are a diverse group of neoplasms with the important clinical significance, and clinicians should be aware of their symptoms to prevent irreversible neurologic dysfunction. I thank you for your attention.
Thank you very much for the presentation. We have a question from the participants. How do you evaluate which patients will have a permanent neurological deficit?
How to evaluate?
Which patients will have a permanent neurological deficit?
For example, it's important at the diagnosis how much the neurological dysfunction occurs. For example, if the patient can evaluate her or his lips against gravity, or if he was immobile longer than 2 days, probably it will be non-ambulatory.
I'm handing over the microphone to Dr. Özkan Ateş.
Hello, everyone. I want to present minimally invasive techniques in spinal tumor surgery and and then I want to share our experience in this issue. First of all, spinal tumors are being detected at earlier stage and smaller size than before. The general trend in spinal surgery has been minimalization. Of all spinal tumors, nearly 50% are extradural, 40% are intradural extramedullary, and 10% are intramedullary tumors. 90% of spinal column tumors are metastases. The realistic objectives of the surgical treatment for any spinal tumor must be clearly defined. In some cases, diagnosis may be the primary goal. For a number of primary spinal column tumors, lasting cure is the goal of surgery, and as such, the choice of surgical technique is critical in achieving access and definitive excision. Numerous studies have demonstrated that negative margins with en-bloc resection of primary malignant tumor of the spine significantly decrease recurrence rates and prolong survival. For most metastatic lesions, symptomatic relief and palliation are the most common goals of surgical intervention. Therefore, the effects of any selected treatment on the patient's quality of the life must be carefully considered. Principles of treatment goals, diagnosis, tumor removal for local control or cure, circumferential spinal cord decompression, symptomatic pain relief, and the stabilization of the spinal segments involved. Commonly, complications of traditional approach, traditional circumferential open decompressive operation for spinal metastasis can carry up to a 30% complication rate. These complications, neurologic deterioration, severe medical complications, massive hemorrhage, wound infection, hardware complications, CSF leaks, and death. Which indications for minimally invasive techniques, intractable pain, neurologic deficit, spinal deformity, need for diagnosis, and tumor cure or tumor control. Minimally invasive techniques we can divide two main groups. First of all, percutaneous techniques and another surgical techniques. Percutaneous techniques, percutaneous radiofrequency ablation, SRS, stereotactic radiosurgery, vertebroplasty or kyphoplasty, percutaneous injection or pharmacologic agent, tubular guide sleeve system for image-guided percutaneous biopsy or evacuation, percutaneous pedicle screw fixation. Common surgical techniques, endoscopic surgery, endoscopic assisted surgery, and minimally access apparatus. Percutaneous radiofrequency ablation is performed only the lesion is no closer than 1 centimeter to the thecal sac or closest nerve root, and that a layer of cortical bone is interposed between the tumor and neural structures. Percutaneous RFA has been safely and effectively used to treat especially osteoid osteomas. 90% rate of the pain relief, no complication, arrest the tumor growth in all cases on follow-up. Percutaneous injection on pharmacologic agent is an alcohol solution injection, for example, calcitonin and methylprednisolone, to induce ossification in patient with pain but without neurologic compression or spinal instability. Duncan, a cervical angiosarcoma metastasis, intratumoral bleomycin, palliative measure. Another percutaneous technique is a tubular guide sleeve system. Varga described this technique have a narrow tubular guide sleeve system for image-guided percutaneous biopsy or evacuation of spinal column tumors. Another minimal invasive technique is a stereotactic radiosurgery. This technique focuses high dose of radiation on a neoplasm under FRAMDAS image guidance in a single stage or hypofractionate stage with minimal exposure to surrounding tissue. Another speaker we will talk about the SRS. Vertebroplasty or kyphoplasty, another minimally invasive technique for spinal tumors, originally used for the treatment of vertebral hemangiomas. You can see that this patient is a C6 hemangioma, 36 years old female. You can see is a coronal section, axial section. And we can do the percutaneous vertebroplasty for this hemangioblastoma for patient relief. After the vertebroplasty, you can see the bone cement in C6 vertebra. Another patient, L3 hemangioma, you can see the CT scan, sagittal section, coronal section. We can do the kyphoplasty for this hemangioblastoma with percutaneous kyphoplasty for pain relief. Vertebroplasty and kyphoplasty, the intent of these procedures is to provide immediate lasting pain relief and some degree of stabilization to the affected vertebral segments. Ideal patients for vertebroplasty or kyphoplasty, intractable pain, multiple levels of disease, a limited life expectancy, 3 to 6 months. Other surgical interventions cannot tolerate. We can use vertebroplasty or kyphoplasty techniques. Complication rate, the frequency of the PVA procedure is higher in patients who have tumors 5 to 10 than in patients who have an osteoporotic fracture 1 to 3 or hemangiomas 2 to 5%. In this slide, you can see the pain relief ratio is very high. Nearly 100% is very successful techniques you can think. You can see another article, pain relief ratio 100%. Another. This patient is a 70-year-old man, multiple myeloma, L1 pathologic fracture. Period of VES 8, post of VES 2, after 3 months VES 0. Vertebral body restoration 52%. First of all, you can see is a vertebra T1 weighted sagittal section MRI. Is a X-ray lateral view. After the kyphoplasty, you can see that is a vertebral high restoration. 52% nearly. Endoscopic surgery, thoracoscopic surgery represent a major advance in minimizing approach-related morbidity in the treatment of spinal tumors. 3 to 4 port placed via small incision in the chest wall, visualization of the ventral thoracic spine from T3 to 12. Using a rigid endoscope, specialized long instruments to perform the corpectomy and reconstruction. The patient, 36-year-old woman, operated breast carcinoma, You can see in this MRI T5 pathologic fracture. Patients has a thoracic back pain and tenderness in the 6 months. Several localized back pain in 5 days, no deficit. You can see another T2 weighted MRI. We did the thoracoscopic corpectomy for this patient, and then after the corpectomy, we put the interbody cage between 2 vertebral corpus. After the surgery, you can see there is an X-ray. This view is a perioperatoire view. Thoracoscopic surgery advantage of the technique include less incisional pain, earlier ambulation, shorter hospital stays, decreased incidence of complication. Endoscope-assisted surgery have also a use to perform open operation less invasively while still ensuring complete decompression. The patient is a 28-year-old man, T12 primary benign bone tumor. Patient has a thoracolumbar back pain. You can see this tumor, benign bone tumor. You can see the axial CT and coronal CT. Patient has a back pain. First of all, we use is a biopsy. After the biopsy, we put the bone cement in the tumoral lesion and reconstruction with bone. Minimal access approach is performed through approximately 4 to 6 centimeter skin incision. The advantage of using a special retractor system permit continued visualization through the constrained working space. Using 3D imaging, microsurgical instruments, magnification as you like, safety and control of bleeding for this technique. You can see 54 years old woman, C2 tumor. You can see it is an axial view, C2 tumor, sagittal view, sagittal CT scan, C2 tumor, MRI view, this is a tumor, C2 tumor, and axial view, axial MRI view. And we can do this surgery like this technique, transoral macrosurgical approach, total tumor excision, and we can use the polymetal metacrilat with Kirchner constructed is a C2 vertebral body and dense. This is a pathologic diagnosis for this tumor is a chordoma. After the operation, you can see the CT scan. We remove all of the tumor and reconstruct the C2 vertebral body with Kirchner and polymetal metacrilat. Third year's view in this picture, you cannot see any nukes and residue. In this picture, you can see is a functional MR. There is no instability for surgical area. Another patient is a 57 female. Patient has a progressive paraparesia, T7 epidural mass lesion, and cord compression. In this T weighted MRI, you can see axial view. We use a 4 centimeter incision microsurgical approach. They compress the spinal cord and we used polymethyl metaclot with Steinmann pin. Postoperative first day, patient's paraparesia improve. Second day, we discharged the patient. You can see this is a X-ray and CT view. Another patient, 21 years old, female, inability to walk, inability to hold heat high. The patient's complaint gradually increased for 6 months. He has torticollis. He cannot move. More prominent spastic quadriplegic in lower extremities. DTRs hyperactive in all 4 extremities. The patient has been diagnosed with Ewing sarcoma since 2012 and has a history of various surgery, chemo, and radiotherapy. You can see the X-ray lateral view. There is a spinal deformity, especially upper cervical area. This is a MRI view. You can see this is a upper cervical tumor, and there's a lower thoracal metastatic tumor, Ewing sarcoma. This is a cervical tumor, MRI view, and CT. This is a preoperative lateral view. We reconstruct the upper cervical area. You can see we improve the kyphotic angle, especially upper cervical area, and we fixed this patient from occipital condyle to C5 vertebra. First of all, we do this patient is a separation surgery, and then we used condyle screw and pediculus screw, and we stabilized this upper cervical area for this patient. Preoperative CT scan. After the operation, we can use remodeling the C2 vertebral body and dance. Can see this kyphotic angle improved postoperative period. Yes. Another patient, 60 years man, inability to walk. The patient's complaint has been present for 1.5 months. Spastic quadriplegic. Patients' DTRs are hyperactive in all 4 extremities. In the lateral view, there's a kyphotic deformity, upper cervical area. You can see this upper cervical tumor, upper thoracal and lower thoracal tumor. This tumor, upper cervical tumor, compressed the spinal cord. You can see, and upper thoracic and lower thoracic tumor compressed the spinal cord too. We operated the patient. First, we used the separation surgery and stabilization for cervical, upper cervical lesion, upper thoracic lesion, and lower thoracic lesion. Separation surgery, occipital condyle to C6 stabilization, T2 to 4 and T7 to 11 stabilization for these patients. After the operation, remodeling the C2 vertebra, preoperative view, postoperative view. You can see in this CT, we remodel it is a C2 vertebra. Yes. Another patient, 66 years, female, back and both leg pain. Patient had a spastic paraparetic. You can see that this tumor compressed the spinal cord in the thoracic area. The CT scan. We operated the patient. We used the separation surgery. Decompress the spinal cord and stabilize the T7 to 11 thoracal tumor. Another patient, 54-year-old woman, you can see there is a presacral giant tumor. You can see is a angiographic view, and we embolizate the tumor first of all. You can see the surgical view. We excise the coccyx and S5 retrorectal presacral approach. You can see total tumor excision. This tumor's pathologic diagnosis was schwannoma. Minimally invasive approaches to spinal tumors have evolved dramatically over the past 15 years. Their indications, efficacy, and limitations continue to be defined while new technologies concomitantly emerge. The next generation of minimal access approaches may include novel biologic and genomic therapies that are implanted in the minimal invasive patient to treat neoplastic disease of the spine and spinal cord. Well-controlled studies with large numbers of the patients are needed to better determine the indications, risks, and benefits of minimally invasive techniques compared to more conventional approaches. Thank you for your attention.
Thank you, Doctor. We have a question from our participants. Do you ever use parallel approach for clivus chordoma, and do you think it's an efficient method for a surgery?
Yes, we use transoral approach for clivus chordoma. Sometimes we use another technique, transnasal approach for clivus chordoma. Commonly we use is endoscopic techniques. We started newly for robotic surgery for especially clivus chordoma surgery, and robotic surgery and endoscopic surgery we can use safely after tumor surgery for chordomas. Commonly we use SRS or another radiotherapy techniques.
Thank you very much. I'm handing over the microphone to Dr. Nilüfer right now.
Good afternoon to everyone. I would like to welcome all of you to my talk today. I would like to introduce myself. I am Nilüfer. I have been working as a radiation oncologist at Koç University Hospital since 2017. Today, the topic of my talk is targeted ablative radiotherapy called stereotactic body radiotherapy. My speech will be on our highly specialized new technique of radiation therapy, which we call Sbrt. My presentation outline plan will include definition of Sbrt, giving some details about technical aspects of Sbrt, try to explain radiobiology of it, and go over guideline perspective of clinical indications for Sbrt. When we look at the definition of Sbrt, also called Sbrt, Sbrt is a new, advanced, or modern technique of radiotherapy, which is highly focused and precise, allows us to deliver high focal ablative doses to any required target extracranially within similar principles of cranial radiosurgery practice for decades. The treatment course is within 3 to 10 fractions, mainly completed in 3 or 4 fractions. It can be delivered in a single fraction or in multiple fractions. Single fraction delivery, usually called SRS. It is 1 large dose instead of 30 fractions, which is as in standard radiotherapy. If it is multiple small number fractions, for example, between 2 to 5 fractions, often called hyperfractionated stereotactic radiotherapy or fractionated stereotactic radiosurgery. Sbrt is more than a technique, a machine, or a modality. It's like a combined approach, uses fine precision, high dose per fraction, small margins, and steep dose follow-up to spare normal tissue. So we are aiming to maximize the therapeutic ratio. Because of the high dose fraction, it is much less forgiving than conventional treatment and requires more technology for guidance and assurance. It requires extra effort for tumor delineation, immobilization, motion management, image guidance, and treatment delivery using string QA standards and metrics. And also the important thing is a very well-trained team to make sure we are doing it safely. Modern radiation techniques help us use Sbrt and helps maximize the therapeutic ratio. We can give non-uniform doses and even simultaneous boosts to areas that need it. We also can do isotoxic plans where we limiting risk to the organs at risk while giving a substantial dose to the tumors. So remember old school, all we could offer people was simple plans, large treatment volumes, and only intended palliation. However, now we have complex treatment plans, multiple beams, we can spare normal tissue, and now we start to question, can we do more than just palliate? Can we efficiently improve survival? Target delineation is very important when we are giving high dose per fraction and using smaller margins. We need to take extra effort to make sure we are delineating our tumors correctly. The fusion of images is very important, especially getting them in the treatment position. Also, IV contrast can be helpful. Of course, for the imaging is important because many of the tumors move and we want to model that and account for it in our treatment. So when we mean 4D CT, it is a basic CT that counts the breathing motion during one respiratory phase. You can imagine when we wave our hand, wave means motion of the lung. CT captures only a phase of the movement, but with 4D CT, the images starts from the beginning to the end of the wave action. So we cover the tumor in all phases of respiration, and the name of the target that we delineate called internal target volume. This is the advanced breath management technique for the CT scans, which can track tumors with remarkable precision. When we look at image guidance, it's important because the more conformal our treatment, the more we need to see what we are treating. IGRT integrated into radiation oncology equipment to ensure accurate tumor position, allows for greater assurance of tumor control, decrease margins, less normal tissue being irradiated. Volumetric 3D information is accurately evaluated to verify setup and target location, quality assurance that the planned treatment is delivered correctly. So in order to be able to increase the therapeutic ratio, we have to take a look at our dose response curves. The tumor in red, as you see here, and the normal structures is in blue. The goal is to give as much dose as we can, being safe with the normal structures. We want to make sure we are getting as much dosage as we can and limit the volume of the intermediate dose to prevent the risk of having complications. And we spray a low dose wide around since it is not the range of toxicity risk. We go from a small dose to a large dose. This is a good paper to understand mechanism of radiobiology of Sbrt. We start by killing of our oxygenated cells and then our hypoxic cells through direct action on the DNAs. And as we hit that number of 10 to 12 gray per fraction, we start to get into damaging the endothelial cells with indirect action. There is an interesting study in which they did a biopsy before treatment Sbrt, and they did surgery afterwards. The H&H stains showed increased necrosis, and they realized that it took a little time to reach that level of increased necrosis. While on the same day of Sbrt, there was no necrosis. The following day, there was necrosis, and they also looked at the macrovessels and saw a density decrease, showing there is a DNA damage as well as vascular damage. When we look at the guideline perspective of indications of Sbrt, it allows us to take place in management of early stage cancers such as lung or prostate tumors with curative intent. Sbrt also recommended for unresectable hepatocellular carcinoma and locally advanced pancreatic cancer. Also for patients with recurrent head and neck cancer, there are promising results of prospective phase 2 trials. For these patients, the gold standard is still going to be surgery after period definitive radiotherapy. But due to the toxicity with other regimens, Sbrt getting to be more and more an option due to its short duration and acceptable toxicity. You can see here select practice changing trials of Sbrt for both medically inoperable and operable non-small cell lung cancer patients. One of them is RTOG 0236 phase 2 multicenter study of Sbrt for patients with inoperable non-small cell lung cancer. Here treated with Sbrt had a survival rate of 40% at 5 years. 55 patients were enrolled in this study. There were high rates of local tumor control, more than 93% at 5 years with Sbrt. In the pooled analysis of 2 studies, STAR and ROSAL, a total of 58 operable non-small cell lung cancer patients were enrolled and randomly assigned 31 to Sbrt and 27 to the surgery lobectomy. Median follow-up was 40 months for the Sbrt group and 35 months for the surgery group. Estimated overall survival at 3 years was 95% in the Sbrt group compared with 80% in the surgery group. Grade 3 to 4 toxicity, 10% for Sbrt versus 44% for surgery. Although based on a small pooled randomized experience, these data suggest that Sbrt may in the future become a viable non-invasive option for selected patients with early stage operable non-small cell lung cancer. This is a recently published study meta-analysis of over 6,000 prostate cancer patients treated with only 5 sessions of a non-invasive Sbrt. Reported cancer control rates of 95% for 5 years and 94% for 7 years. Furthermore, the risks of significant long-term bowel and bladder side effects are remarkably low, less than 2%. Data from over 40 prospective studies have established that Sbrt is the new standard treatment for the vast majority of patients with the most common prostate cancer, low and intermediate risk, can be treated with a fast 5 sessions course Sbrt. Also, Sbrt has been successfully used to treat hepatocellular carcinoma. A number of prospective phase 1 to phase 2 trials have shown that Sbrt is well tolerated with excellent local control between 80% to 100% for 1 year and relatively good survival rates. Sbrt can be used effectively for both early and locally advanced hepatocellular carcinoma, as shown by the 4 larger prospective photon-based Sbrt trials is shown here in this table. Sbrt also can be adapted to multiple situations in metastatic sites. We have evidence, especially for non-small cell lung cancer and prostate cancer metastasis. Liver Sbrt is especially hard to talk to our colleagues and get them excited about it. But as we learned more how the normal tissue responds in the liver, we have been better able to target specific parts of the liver. Sbrt has become an excellent modality for these people. MRI is effective for tumor delineation, and Sbrt has also been found effective for liver metastasis. However, the studies are of limited size. In metastatic disease, Sbrt is used in cases of oligometastasis, oligoprogression, and oligopersistence disease. Oligometastasis is the state in which the patient shows distant relapse in only a limited number, 1 to 5, up to 10 of regions. There are some state definitions for oligometastatic disease. One is oligoprogression, one or a few progressive lesions in a polymetastatic context, while all other lesions are controlled with systemic treatment. Oligopersistence means oligometastatic residual disease after systemic treatment. Oligorecurrence is oligometastatic relapse after primary disease control. In 1995, Drs. Hellman and Vaxoven wrote an editorial that coined the term oligometastasis, described an intermediate state exists between local and widespread disease, and refined the hypothesis of metastasis-directed surgical and radiotherapeutic treatments as potentially curative for select patients. When we look at the answer for question why Sbrt for oligometastatic disease, highly targeted radiotherapy, Sbrt, is included in many ongoing treatment protocols to control oligometastasis to increase disease-free survival under same systemic treatment, delay administration of further systemic complicated treatments, decrease tumor load, enhance immunotherapeutic responses by abscopal effect of radiotherapy, fight with chemo-targeted drug resistance, and improve the quality of life in different settings. Today, immunotherapies are used very intensively and effectively. There's a great amount of interaction between radiotherapy and immunotherapy. Immunogenic cell death is quite limited in cases where radiotherapy is administered alone, but it has been shown to have therapeutic effect on tumor cells outside the field in combination with a number of immunomodulatory agents, especially immune checkpoint inhibitors called abscopal effect of radiotherapy. This is the first randomized study, Saber-Comet. Background is based on historically the treatment of patients with the metastatic solid tumors has been based on systemic therapies that aim to delay progression and extend life, but not to eradicate the disease completely. The oligometastatic paradigm, formally named in the 1990s, but anecdotally reported as early as the 1930s, suggests patients with a limited number of metastases should be amenable to a curative treatment approach. So, in this study, to assess the impact of a Saber on overall survival, oncological outcomes, toxicity, and quality of life in patients with up to 5 metastatic cancer lesions and a controlled primary tumor compared to standard of care treatment alone. This is the study schema. Patients with up to 5 metastatic lesions were randomized arm 1, which is standard of care, and arm 2, Sbrt to all sites of known disease. For the primary endpoint of overall survival, the Kaplan-Meier curve is shown here. The Sbrt arm is in blue and the control arm is in red. The median of overall survival was improved from 28 months to 41 months. For progression-free survival, the curves are here. Median progression-free survival was doubled from 6 to 12 months. No systemic treatment changes. The control ratio of lesions was significant in the Sbrt arm. No change in quality of life was found. Last year, long-term report of international randomized phase 2 trial Sbrt Comet was reported. Patients who received Sbrt demonstrated a 22-month improvement in median overall survival compared with patients who received a standard of care approach alone, corresponding to an absolute survival benefit of 25% at 5 years. There were no new safety signals detected. To summarize, Sbrt is an important multi-purpose tool in managing cancer. Improvements in technology, image guidance, immobilization, diagnostic imaging, treatment delivery are supporting greater ability to target and treat a growing number of conditions. Efforts to ensure safe and effective delivery of Sbrt is critical. The excellent tolerance profile of Sbrt makes it highly competitive compared to surgery, thus making its integration in a multidisciplinary strategy appropriate even for fragile patients and allows for repeatability. Growing evidence supports the role of Sbrt, but more is needed. Thank you very much for your attention.
We thank Dr. Nilüfer for her presentation. We have a question from our participants. Is it proven that the use of 4D CT diminished the complication rates caused by the radiation?
Exactly. We can, as I mentioned in my presentation, we can protect the normal lung tissue with using 4D CT. And meanwhile, we can give higher doses to the tumor, and it means local control is high.
Okay, thank you. Thank you very much.
Thank you.
Now I'm handing over the microphone to Dr. Duygu. Dr. Duygu will be right with us.
Thank you, Dr. Erim. Good afternoon. Let me introduce myself shortly. I'm Dr. Duygu Sezen from Koç University School of Medicine, Department of Radiation Oncology, and I'm working here since 2014. The purpose of this session is gonna be to present a framework to evaluate patients with spinal metastases. I'm gonna do this in the context of a specific case, but ultimately this context can be applied to all of the patients with spinal metastases in our clinic. The spine is the most common site for bone metastases, and spinal involvement occurs in up to 50% of the metastases, and it comes from usually breast, lung, or prostate cancers. And spinal radiosurgery is the application of high-dose radiation to the disease area with spinal radiosurgery, and while doing this, we try to protect the surrounding tissues. Sbrt and Sbrt is the same thing actually, and we can do this several kind of machines. So we know that with stereotactic body radiation therapy to the spinal metastasis, we can cure some of the meds, and we can have local control up to 96% of the patients with long follow-up times and without any myelopathy. So if we start with our case, we have a 60-year-old gentleman with the history of renal cell carcinoma who had a nephrectomy 5 years earlier. He presents to clinic in the lumbar region, it's with a pain in the lumbar region, and he says he rates 7 out of 10. He says the pain is constant and does not get worse with movement. He undergoes a CT scan and actually does not show any evidence of disease. And then ultimately, he has a PET scan that reveals an area of increased uptake in the L3 region. Then he undergoes an L-spine MRI that shows a 1.7 centimeters mass in the L3 body, suspicious for metastasis. And you can see the picture here, that MRI as sagittal and axial images. The patient has a complete spine MRI, which shows no other sites of metastasis. And because it is the first site of metastatic disease, he undergoes a biopsy that confirms the lesion includes the renal cell carcinoma cells. He comes to the clinic to discuss the management options. The neurologic exam does not reveal any deficits, and the only thing notable is a little bit of tenderness to palpation in the L3 region. So how should we manage this patient? Here is the best framework that I've seen and published by Memorial's Lung Catering Group, and it is called NOMS framework, which looks for 4 specific factors: neurologic, oncologic, mechanical, and systemic. I'm gonna go through each of these in turn. Let's start with the neurologic evaluation. There are really 2 things that we look at from the neurologic view. The first thing is the extent of epidural disease. And Bilski grading scale is the most common system used for this purpose. Grade 1 is in which a patient with some epidural involvement but no spinal cord compression. Grade 2, which has a spinal cord compression, but there is still remaining CSF. And grade 3 is the disease with a spinal cord compression with no CSF visualized at all. And the extent of epidural disease really makes a large impact on our patient's local control. This is a retrospective series of patients that treated with 12 times 2 using Sbrt. You can see dramatically higher rates of local recurrence in patients with epidural disease. The second thing we would like to evaluate is neurologic function. ASIA is the most commonly used scale for this purpose. It goes from grade 1, grade A, which is absolutely no neurologic function, and down to then E, which is a patient who is neurologically intact. For our patient, you can see the lesion is localized in the body, and there is no epidural extension, which is Bilski grade 0, and he has an ASIA E disease with completely normal function. And as a result, this patient is a really good candidate for non-invasive option. He does not require any sort of decompression. So the second thing we're gonna look at is oncologic factors. This is a table showing the radiation sensitivity for tumor for conventional fractionated radiation therapy. We have radiosensitive primaries like lymphoma, myeloma, and seminoma, and we have some tumors that are much more radio-resistant like sarcoma, melanoma, and renal cell carcinoma. Fortunately, the dose escalation that we perform with Sbrt allows us to get around this. And we have comparable excellent rates of local control across these histologies, even the radio-resistant ones. So to apply this to our case, the patient has renal cell carcinoma, which is a radio-resistant tumor, and this makes our patient a very good candidate for dose escalation with Sbrt and also to maximize our local control. The next thing we always want to look at is mechanical stability. The scale that we commonly use is SIN score, and for example, SIN score 12, more than 12 is absolutely unstable. We need to ask these questions in the scale to our patients which have spine metastases to characterize their pain. For example, is your pain constant or it is mechanical? So mechanical means that you are perfectly comfortable when you are lying bed, but when you move, it hurts. Patients with mechanical pain are not going to benefit from radiation alone, and they really need stabilization, either cement augmentation or some sort of actually invasive surgical stabilization. So, talking about our patient, this patient does not have any pain with movement and he does not need stabilization. And finally, we always need to look at the big picture. We are all aware that overall management really depends on how the patients are doing, how are their prognosis, and how long they are gonna live, which are driven by both tumor biology and the extent of the disease. For this particular patient, L3-Met is the only site of disease, and as a result, this is a very compelling patient for dose escalation with Sbrt. So when we decide to treat this patient with Sbrt, we need to consider how we're gonna do that. The first thing after our scans is to identify the gross disease, and there are several studies that worked on delineation of tumor volumes on vertebral metastases. This framework is extremely helpful while trying to delineate the CTV for patients with spinal metastases. This table can be seen a little bit overwhelming, but it's simple actually. For example, the only thing that we need to do is treating the real tumor and the entire compartment that is located and the adjacent location of the vertebra. The only exception for this, if you have a patient with a disease in the entire body, it is okay to treat just the body, no need to treat the adjacent compartments. What they did is they divide the spinal level into 6 segments, and we have the body as a number 1 and the pedicles as number 2 and 6, and also transverse processes and laminas as numbers 3 and 5, and finally spinous process as number 4. So consider target delineation for our patient. We circle the lesion as a gross disease, and this is the also exception, and we all need to treat the body itself. After we delineate the disease, we need to delineate the organs at risk, and the most important one is the spinal cord. For spinal cord constraints, typically we use is 5% risk probability, but actually the risk of spinal injury is much more lower with our new techniques. So this is the treatment. This is the treatment timeline for all patients. So when we come to the acute toxicity, there is a peak in 3 months. Sorry for that. And the most common toxicity is pain flare. We usually see that just after finishing all the treatment, and we usually give dexamethasone, and then it usually settles down in 10 days after the treatment. Also, there is a peak in 3 months after Sbrt, and we usually, actually, we see it. So, and the risk of fracture is also dose related. So it's important to evaluate the dose and critical organs at risk doses very carefully. And if we give the doses more than 24 grays, usually we see more commonly the vertebral compression fracture. So, as a conclusion, Sbrt is an emerging field with great promise for patient care, and with development of oncologic treatments, it's making these metastases more important. And we know that we can increase local control with radiosurgery, and as we know, also multidisciplinary approach is the most important thing for managing this kind of tumors. Thank you.
We thank Dr. Duygu for her beautiful presentation. We have one last question. What is the preferred dose for spinal Sbrt?
Okay. We can use different dose schedules. We can give the dose in one single fraction between 18 to 24 grays, or we can give it as 12 times 2 in 2 fractions, or we can give it in 3 fractions, like 7 to 9 grays in 1 fraction. Also, we can modify it as 5 fractions, and we can decide the dose and the fraction numbers according to the critical organs, and we can meet the criteria of critical organs with this kind of evaluation.
Thank you for the detailed answer. We would like to thank our physicians for the presentation and our participants for joining us today, and hopefully we will meet again for our next webinar. Please don't forget to follow us on Instagram for the new webinar announcements. You can reach the new webinars using the same link. Hope to see you soon.